Good afternoon, everyone. David Jordan. I'm the president and CEO of the United Methodist Health Ministry Fund. Thank you for joining today's webinar on the impacts of HR 1, known as the One Big Beautiful Bill Act, and changes to the marketplace on Kansas. As you all know, Medicaid is the largest source of federal funding in our state budget and covers an estimated 400,000 Kansans. Kansans and Kansas providers, especially hospitals, rely on Medicaid funding. As you know, Kansas has more financially vulnerable hospitals than any other state in the country. As a result, any changes to Medicaid financing will have an outsized impact on access to care, hospital and health centers, and the state budget. Also, as a state that has not expanded Medicaid, Kansas has seen a large increase in the number of Kansans who took advantage of subsidized ACA marketplace plans over the last several years. In fact, last year, there was record enrollment in ACA marketplace plans. However, changes to the marketplace rules included in HR 1 and the failure to extend tax credits that makes plans more affordable threaten those coverage gains in Kansas. Understanding that changes to Medicaid and the marketplace would have a significant impact to Kansas, we are proud to partner with the Reach Healthcare Foundation and their president and CEO, Brenda Sharp, who you'll hear from later, to work with Manatt Health, a leading professional service firm, to analyze the impact of these changes on Kansas, on the state budget, and on providers. Today's webinar will provide insight into how Kansas will be impacted and offer discussion and insights into how we can prepare for the changes ahead, as well as how to better understand how the Hospital Association and Community Care Network are approaching these policy changes. Now onto some quick housekeeping items before we get started. First, given the large number of folks on this call, your lines are muted. However, we hope you can use the chat function to engage throughout the webinar. Please introduce yourself in the chat. Also, please ask any questions in the chat. We will be monitoring the chat throughout the webinar, and we'll take questions after the presentation and panel discussion. Given the large number of folks on the call, we will just use the chat for question and answer. So please don't hesitate to put any comments into the chat. We will also be sending out the presentation and a recording of the presentation following the webinar. We look forward to a robust discussion and to ongoing partnerships ahead as we work to sustain access to healthcare in Kansas. To kick things off, we'll share a little bit of background on the foundations and our presenters, and then we'll hear from Cindy Mann from Manatt, from KHA and CCNK, and then time for question and answers. As we offer up some additional background on the two foundations, I'll invite my colleague Brenda Sharp, President and CEO of the Reach Healthcare Foundation, to provide some background on the great work that Reach does.
Thank you, David. Welcome, everyone. We're really grateful for the high level of participation on this call. Within 2 hours of putting this notice out, we had 80 registrants, and as of this morning, we had over 180. I know people fall off, but it does tell us that there is a lot of interest in this particular topic. Reach Healthcare Foundation was really fortunate that David Jordan, our colleague at United Methodist Health Ministry Fund, reached out to ask us to partner, and the Manatt team has been incredible, as have many other partners who are also included on this call in making today happen. Just quickly, the Reach Healthcare Foundation is a health funder. We are located in the Kansas City area. We have a 6-county service area, but we do regularly engage in health policy advocacy, analysis, and conversations in both Kansas and Missouri. We've awarded about $88 million in grants to many of the groups that are on this call. And we know that Medicaid is an important revenue stream for a large majority of our funded organizations. And more importantly, it's a huge source of care and coverage for many of the priority populations that the Reach Foundation serves. So we appreciate all of you not only coming and educating yourselves, but thinking about how you use this information later to inform your constituents, your boards of directors and trustees, and also your elected officials at the state level who will have to be making a lot of decisions about how to implement these changes that are to come. So with that, I will turn it over to back to my colleague, David.
Thank you, Brenda. We're very excited to have partnered with Reach on this project. A little bit about the Health Fund. United Methodist Health Ministry Fund is a statewide health foundation. Our mission is to improve the health of Kansans. And over our 40-year history, we've awarded $80 million in grants. We have a 17-member board, and we really work to improve the health of Kansans by focusing on access to care, thriving children, and building engaged congregations. Next slide. A little bit about our reactor panel. We are excited to have Cindy Samuelson, the Senior Vice President of Member of Public Relations, join us. Cindy's a longtime partner and has been with KHA for over 20 years, leading a number of functions: public relations, communications, member relations, the PAC, and so much more over that time. We always can trust her to be a trusted partner and advocate to improve access to care in Kansas and to protect Kansas hospitals. Next slide. And we're also fortunate to have our great partners at the Community Care Network of Kansas available to serve as reactors as well. Robert Stiles is the new CEO of CCNK. He joined CCNK earlier this summer, but has a long background in healthcare, having served as the CEO at FQHC in Missouri, director of the Office of Primary Health at KDHE, and it's been involved at the federal level with HRSA and many other entities for many years. We're also joined by Aaron Dunkel, Vice President of Regulatory and External Affairs for CCNK. Aaron brings over 25 years of experience, having served in many roles, including Deputy Director of KDHE, overseeing the Medicaid program, as well as CEO of the Pharmacists Association, and leading efforts for Molina in Kansas over the last several years. So we're excited to have Aaron and Robert. And rounding out our presenters today is Cindy Manatt. Cindy Mann, a partner at Manatt Health. Cindy, prior to joining Manatt, she served as the Deputy Director of CMS, leading Medicaid operations. Cindy has a long history in healthcare and was one of the founders of Georgetown Center for Children and Families. So we've been really fortunate to partner with Cindy and her team at Manatt, who all have done great work over the last year, helping us prepare for every scenario possible through the development of this bill and now the passage. So I will turn things over to Cindy and just appreciate her partnership. Thanks, everyone.
Okay, thank you. Sorry, I'm having a little technical trouble. Just trying to get my screen to be working here. Hold on one second, sorry. Okay. Good afternoon, everybody. I'm really glad to be with all of you and appreciate the interest in this really important topic. I wanted to particularly thank United Health Ministry and the Reach Health Foundation for being such wonderful partners, along with others throughout Kansas, particularly the Hospital Association that's provided some great data, and the state itself. Conforming data. Manatt, just so that everybody knows, has done modeling on all of the provisions, all of the Medicaid provisions, I should say, or most of the Medicaid provisions in HR 1. And we build this model from a state base. So we build it from Kansas data, from Kansas trend rates, and are really careful to try and be as accurate as possible so that you all can have the information you need, both as the bill was moving along, but also now as it has been enacted, and it'll turn to Kansas center stage to think about next steps. So let's jump right in. I'm just going to very briefly, if you go to the next slide, please. Next one after that. So just very briefly remind all of us, and my guess is everybody in this audience participating in this webinar are pretty familiar with how important CanCare and Medicaid is in Kansas in terms of the breadth of its coverage. You don't have the expansion, as I'm sure everybody knows, but it is a very robust program. It covers 437,000 Kansans. It covers kids. It covers, labor and delivery. It covers people at the end of life. It covers long-term care and services. And importantly, in terms of some of the impacts on the Kansas healthcare system, 3 in 10 Kansans who are covered by Medicaid live in rural areas. You also have, as David Jordan referenced, you also have robust enrollment in the marketplace. Over 200,000 Kansans are in the marketplace with record-setting enrollment in the last open enrollment period. We're going to mostly talk today about Medicaid, but marketplace is also a very important source of coverage for Kansans, and therefore also a very important source, or the marketplace is an important source of payment for Kansas health providers. So we'll touch on some of the marketplace issues as well. Going to financing, again, David Jordan pointed out that Medicaid is the largest item in the state budget if you look at federal and state dollars. But as most of you know, 2/3 of the dollars in the Medicaid program in Kansas are federal dollars. And so what happens to those federal dollars is enormously important to the Kansas Medicaid program. And also, I think, as everybody knows, in Medicaid, the state has to come up with its state share of the cost of the Medicaid program. And it does that through a number of different ways, through general funds, as well as through provider assessments and taxes. And we're going to talk about that part of Medicaid financing as well. On the marketplace, it is certainly a strongly publicly financed program in the sense that it is, as it was originally set up in the ACA, it establishes publicly funded, federally funded tax credits to help people with incomes above Medicaid eligibility levels, people not eligible for Medicaid, people in different situations under 65, to enroll in the marketplace. And last year, or in 2024, over $1 billion of tax credits came into the state of Kansas, courtesy of the marketplace. And we've broken this down because you'll hear us talk about it a couple times over the during the webinar, that a not insignificant portion of those dollars, those tax credits, are at risk as they are slated to sunset. The enhanced premium tax credit that was enacted a few years ago by Congress is sunsets at the end of the year, and it remains to be seen if Congress will extend them. So let's go to the, let's start off with the next slide just on general implications. So there's so many implications and there's so many aspects of HR 1. We won't be able to touch upon all of them, but really very much front and center is around what's going to happen to hospital payments and to the Kansas's ability to raise dollars to also support payments both to hospitals and to other health providers in the state. So big takeaways is those payments that have recently been approved by Kansas, called state-directed payments, which we'll talk about in more detail later in a few minutes, will be significantly constrained over time. And those payments have been established by Kansas to be passed through to hospitals through the managed care organizations with whom CanCare contracts, because the base payment rates for hospitals and for many other providers are below costs. And so these state-directed payments really make a big difference in terms of hospitals' ability to keep their doors open and certainly to serve people with quality services. The actual payment that Kansas has set up will be constrained, and also so will be their future, the state's future ability to do those payments in going forward. Sharply curtailed new limits on those state-directed payments, as well as on the provider taxes that Kansas uses to fund those payments for its state share. There's other provisions in the bill. We'll go through some of them sometimes quickly. I should add that you will get copies of the slides, because there's going to be details here that we won't have time necessarily to talk about, but you'll have everything that's here in the slide. And then I think the big question is really this fourth bullet. The big question for Kansas and for all of you is then what happens, right? There's going to be there's no doubt there's a very significant loss of federal funding. A very significant set of constraints on Kansas's ability to finance payments to hospitals and other healthcare providers. a reality of how fragile your healthcare system is already, as David pointed out, in terms of being the state with the highest number of hospitals at risk of closure because of your rural, extensive rural settings. So what Kansas decides to do in light of the deep federal funding cuts will really be the next big chapter in this story. They may need to reduce, if they want to make up some of the lost payments to hospitals, they may need to reduce payments to other providers, or they may look to reduce or eliminate optional benefits and eligibility. So the policy really shifts to the state level to determine what to do. And the statement at the bottom of this slide just reminds us how big a set of cuts this is. This is $911 billion in reduced federal expenditures in the Medicaid program, as calculated by the CBO. Medicaid's a big program, but $911 billion in reduced federal funding is big for even for the Medicaid program, and it's unprecedented in its size. So on the marketplace side, there's a number of things going on. There's provisions in the bill that we'll go through quickly later on that don't change eligibility. Well, there's a little bit on immigrant coverage, but mostly they are going to make it harder for people to enroll or re-enroll in the subsidized coverage through the marketplace. There's also, as I mentioned, the expiration of the enhanced tax credit. So that is still to be determined. Your members of Congress still have an opportunity to preserve those enhanced tax credits as they don't expire till the end of the year. And there's also additional administrative rules that CMS has put out that, again, constrains marketplace eligibility benefits and adds some new paperwork burdens. So let's get to the bottom line of the fiscal impact. I need to say first my caveats, which is that when Manatt does its modeling, we modeled all the key provisions, the big provisions in Medicaid that would affect Kansas, for which there were data. So there's some provisions that we weren't able to calculate, for example, impact on nursing homes. For example, the notion that provider taxes will no longer be available as a funding source besides the ones that are grandfathered in. And we didn't model what the loss of dollars that might create because it's pretty speculative. So where there's no data or where the outcome is very speculative, we refrain from modeling it. And with all of that being said, we still found a cut of about almost $4 billion in total Medicaid funds will be lost to the state in the next 10 years, fiscal 25 through 2034. The reconciliation bill, as probably most of you know, is a 10-year bill. And you see the breakdown here of federal, state, and total. Most of those dollars that are lost are federal. Some of them are projected to be dollars that the state would have otherwise put into the program. So the total loss is what you're facing at this point. Obviously, the state can fill some of that gap or address that gap in many different ways. On the marketplace side, focusing in solely on the hospitals, since this is such since hospitals are hit particularly hard in the bill, they will see a reduction of $2.7 billion in total funding. Under the bill, again, it'll be up to Kansas to see if there's going to be any adjustment in that. So projected coverage impacts is a little bit challenging for us to model at this point. There are some direct changes to eligibility, or to enrollment, I should say, not really to eligibility, because HR 1 puts a moratorium, basically stops the implementation of an eligibility simplification rule that CMS had issued last year. And that bill would have made it easier for children and some seniors, people who qualify based on being 65 and older, people who qualify based on disability, simplifications both in the enrollment process and in the renewal process that would, according to the Congressional Budget Office, would have helped a lot of people gain coverage and maintain coverage. So some of those provisions have been cut back or stalled completely at the federal level. Kansas still will have some opportunity to do this on their own. But the real coverage story, I think, really goes back to the money. right? If Kansas is facing almost $4 billion in reductions in dollars, what will happen to payments to other providers? What will happen to scope of benefits? What will happen to eligibility? Those are all decisions yet to come as Kansas and its policymakers, and hopefully all of you weigh in on what the next steps are. And as we've already said, marketplace coverage is at risk, and this is an analysis done by colleagues at the Urban Institute. About 108,000 Kansans would lose their marketplace coverage over 10 years, according to their analysis, both of the cuts in HR 1 and if the enhanced tax credit were to end. So let's go ahead and start digging into some of the specific provisions. This is a timeline that I'm going to probably leave it mostly to you all to sort through and think about after you think about the specific provisions. It's a bit hard to follow here, but this timeline is about 3 aspects that particularly affect providers, hospitals, but other rural providers, and other providers as well. And so it gives you the dates of when changes are going to happen to provider taxes. For the most part, those changes happen in October of 2026. No new provider taxes can be imposed by the state of Kansas. And then what's left is any tax that you had in place as of July 4th, 2025. And you do have one tax that the state enacted that presumably will be in effect and be grandfathered. You also, on the state-directed payments that I mentioned before, those are the payments that Kansas Medicaid agency can use to boost provider payment rates through managed care. And as of date of enactment, July 4th, 2025, no state-directed payments can exceed 110% of the Medicare rates. Right now, your state-directed payment is at about 190% of Medicare. It's closer to the average commercial rate. So future STPs would have to be much smaller than the one you recently have set up. And even for those grandfathered state-directed payments, starting in January 2028, the state will have to start reducing them to get them down to that 110% level by 10 percentage points each year. All of this is backdrop or forefront really to why Congress decided to put in a rural transformation fund. There was a lot of attention paid and some by folks from your congressional delegation as well as others, that the rural healthcare system is really going to be hurt dramatically by HR 1. And so they set up a transformation fund. You should not think about this fund as just it replaces the dollars that are lost to rural providers, but it does give an opportunity to bring in some new dollars. We'll go through the rules of that to the state to hopefully support and sustain some of the rural healthcare or some or all of the rural healthcare that exists in Kansas. So let's get into a little bit of the specifics here. So I mentioned before that Kansas has submitted a state-directed payment, a new one, to CMS, and it did that before July 4th, 2025. So under HR 1, that payment should be approved, assuming it meets all requirements, which we have no reason to think it won't. And then it'll be grandfathered, meaning even though there's new rules on STPs, that SDP will continue to exist. Okay. However, the law also requires, as I said, that then any existing and grandfathered state-directed payment will need to be cut back gradually 10 percentage points a year beginning until 2028 until it goes to the level of 110% of Medicare payments. And that is almost a cut by about a half once you get down to 110% of Medicare rates. And then in terms of any new state-directed payments, Kansas will be limited by the cap of 110% of Medicare rates. It no longer would have the ability to go up to average commercial rates or any amount above 110% of Medicare rates on new ones. So lots for the state to consider in terms of the impact and what's going to happen in terms of access and quality of care, and how the state might want to address it, and also shape the Rural Transformation Fund. Let's go to the next slide, please. State provider taxes, I mentioned earlier. That's a mechanism that every state other than Alaska uses to fund some portion of its Medicaid program. Kansas uses it primarily to help finance these state-directed payments, payments for hospitals that boost payments above the often well below cost base payment rates. So pretty startling, effective October 2026, no state can impose a new provider tax or increase an existing tax. So that's really taking away a source of financing for the Medicaid program that Kansas and other states have routinely used. They are going to grandfather in the tax that's previously been enacted by Kansas to support that state-directed payment that I mentioned. So that will continue to be in place. And but this change is affecting every state in the country other than Alaska. But it most pointedly Kansas, because of the extent to which your hospitals are at risk. Because of financing and some of the conditions that exist in rural communities across the country. So really big issues there. So that turns us, I think, to this Rural Health Provider Transformation Fund. So recognizing that rural communities and rural health providers were going to take a big hit out of the bill, some legislators on the Senate side added a fund. First, it was $25 billion. It got raised to $50 billion for rural health providers, not necessarily just to hospitals, but to a range of providers, providing primary care as well as inpatient and outpatient care in rural areas. And states need to apply for the funding. The application is going to be later in this year, and CMS is supposed to approve or deny those applications by the end of the year, and then the money starts flowing, and there'll be $10 million and billion dollars, nationwide in allotments over 5 years. Half of it gets distributed to states with an approved plan, and half of it gets distributed really largely to CMS discretion, hopefully with a nod towards what the state proposes in its transformation plans. So we'll see. There's lots of discretion. There's lots of unknowns, lots of discretion at the federal level to shape this, some discretion at the state level to shape it, not just on which providers get the care, but also on, get the funds, but also on what the uses of the funds would be. So, sorry, my computer keeps doing strange things. The next slide gives you a sense of just the distribution of the potential distribution. So I think a lot of people in Congress kept talking about the hospitals and the hospitals being hurt in rural areas, but clearly there was a recognition that that other providers also will be hurting from these reductions in people having coverage and in payments. So what we did is just come up with some illustrative examples of, imagine all of the money that might be owed or that might be allocated. Nothing is owed, since nothing is really an entitlement under this fund, that might be allocated to Kansas. Imagine all of it would go to hospitals, which is not likely. That would give hospitals about $811 million. Again, it's a scenario. It's not something to take home to the bank. But even if hospitals got all of those dollars, it would not fill the gap that just the hospitals themselves, which is that orange bar, are expected to experience as a result of HR 1. And then if the distribution is 80% goes to hospitals, or the proportion relative to hospitals share of Medicaid spending is used to make the distribution. You see under different scenarios that there's going to be big issues, both to make sure that hospitals can get what they need, but also to make sure that other rural providers their needs are addressed as well. So the fund is really not about filling in the gap. The fund is to help really, in some respects, soften the blow. And hopefully it does that in a significant way. So I'm not going to spend more time on this eligibility and enrollment rules. I mentioned it before. Some of them have been, there's a moratorium, so they won't go into effect. These particularly are for elderly and disabled individuals, and to some degree also help children. The thing I would like to leave you with is that while the federal government is no longer going to require states to do this, there's nothing in existing Medicaid law or regulations that would prevent Kansas from doing this on their own. So still a possibility, but again, it could enroll more people and help more eligible people maintain coverage, so it will come at a cost to Kansas. So a couple other Medicaid changes that I just I won't go through. You can look at the slides later. One is to note that retroactive coverage, which has been a feature of the Medicaid program for longstanding feature of the Medicaid program, where you get 90 days of retroactive coverage if you apply and would have been eligible in the prior 3 months. This would be cut to 2 months instead of 3 months, and it will have a particular effect on hospitals, but really also on nursing homes and people getting into nursing homes, because they use that retroactive coverage to be able to assure a spot. Because the application itself can take a long time to get through. The other thing I'll mention is that effective January 2026, you can still expand Medicaid and get the ARPA money. The ARPA money disappears for expansions. Still get the 90% enhanced match for expansion. So I don't want anyone to be confused about that. It's still quite a good economic deal to expand, but the extra bump that was provided under ARPA will expire in January of next year. Let's go to the next slide. I'm going to just note here that there's a number of marketplace changes in the bill. Again, these don't change eligibility. These really change some of the rules for applying and really for reconciliation and what you may owe back if your income turned out to be different than what you thought it was when you applied for the marketplace premium tax credits. Let's go to the next slide. Go to the next slide, please. There's also some eligibility limitations for the marketplace. Basically, the marketplace was able to cover people who are lawfully in the country, but whose immigration status did not meet Medicaid standards. And so if you were below 100% of poverty, you could still qualify for marketplace. Again, you needed to be lawfully present, but that has been changed by HR 1 and a couple other changes related to that. Let's go to the next slide, if you would. As noted before, the enhanced premium tax credits, I keep harping on this because it's the next big congressional health action to be taken, which is whether they decide to extend it. The leadership has so far been reluctant to consider it, but there may be enough concern after HR 1 that they shouldn't increase the number of people who are uninsured yet again. And so I don't want to foreclose the possibility that Congress may in fact act to sustain those subsidies, but not without some effort. Okay, if you would keep going. So let me just wrap up about what's at stake for Kansas. I think you can all gather what's at stake for Kansas. It is a very large reduction in dollars and not a direct change in eligibility, but one always just needs to follow the money, right? When there's a hole in our Medicaid budget, states have to do something about it. So if the federal government is not spending what the program has currently operating needs, then changes have to happen. And whether that's provider rates go down, and whether that's benefits are constrained, where there's lots of optional benefits in the Medicaid program or optional eligibility in the Medicaid program. the state, of course, can invest state-only dollars to be able to fill the hole. So it really turns to all of you to help shape the next chapter, which is, we've got rural communities that are really their fragile health system is really going to be very much more at risk than it's been. We have people at risk of potentially losing some benefits or losing or eligibility altogether, or just finding more paperwork burdens and difficulty getting coverage and retaining coverage, even though they're eligible. So, so the history of HR1 really is still to be written, or the story of HR1 still to be written by each of the states and how they react to it. So let me stop there, and we can turn to the other members of the panel.
Thank you very much, Cindy. We really appreciate your time and effort that you've put on into this effort. And I know I've learned so much, and we are so grateful for your partnership. I'm going to turn this over now to our reactor panel, Cindy Samuelson with Kansas Hospital Association. Do you have some reactions or thoughts you'd like to share?
Thank you so much. And thank you to Cindy and David and all the folks that have been behind the scene, including you, Brenda. We appreciate being a part of this group. And just as a reminder, the Kansas Hospital Association has 124 member hospitals across the state. So on behalf of them, I'm thrilled to be able to react to this report. It's important, I think, to know that and you've highlighted this, that Medicaid is an essential source of support for our healthcare system in Kansas. So Kansas hospitals specifically rely on Medicaid reimbursement, which accounts for 15% of our inpatient days on average. So any reductions to this program will create challenges for hospitals, especially at a time where many national studies are showing 67% of Kansas hospitals are already operating in the red. In addition to hospitals, reducing Medicaid funding does also increase the number of uninsured Kansas, which is another concern for Kansas hospitals. This increase in the uninsured drives up uncompensated care and shifts costs to everyone in the state. It's important to also highlight that the report talks about the impacts of cuts to Medicaid. Even small reductions in Medicaid would not be limited to just Medicaid beneficiaries and hospitals, but would also harm everyone, working families, seniors, children, all local economies across the state. So it is more, Medicaid is more than just a healthcare program. It's really an economic stabilizer for our state. It's a rural lifeline to many of our rural hospitals. It safeguards all of us. A couple things I wanted to note and really draw attention to is that members of our Kansas congressional delegation really helped mitigate provisions on a federal level that could have been more harmful to hospitals and patients. So there are impacts for sure, and why we were talking about those today, especially over the next decade. But without some of that leadership we had on a federal level from our delegation, Kansas hospitals, we believe, could have faced much more immediate and significant losses. So we just really appreciate that work. It's going to be crucial for Congress to continue to work and for us to work to eliminate any further harmful phase down, as what Cindy alluded to phasing down to 110% of Medicare, because that would really impact the long-term stability of Medicaid support to Kansas hospitals and for the critical services they're providing. A couple other things in the report to react to: the provider assessment or state-directed payments. It's important, I think, for folks to know that Kansas hospitals receive only 65 cents on every dollar of care that they provide to a Medicaid beneficiary. The Kansas Provider Assessment Program really helps offset the difference between the cost to provide care and the amount hospitals are reimbursed for that care by Medicaid. So it's really important. That's why we were so grateful that the state legislature approved an increase to that provider assessment over the last couple of years to really draw down additional federal dollars to support hospitals and providers in our state. Also, the report and Cindy highlighted the Rural Health Transformation Fund, that program. We really are thrilled to have that additional support. It will not fill the gap, as the report notes, but we believe we can expect at least $500 million over the next 5 years, but it's only a short period of time. Also important to note that. And we'll probably receive more based on our state's rural characteristics. I wanted to make sure to highlight that the Kansas Hospital Association is working very closely with the Kansas Department of Health and Environment to apply to CMS to to get this funding for our state before the December 31st deadline. So we will be eligible for this funding. So we're working very closely to make sure that we can get as many dollars as we can for Kansas. Before I turn it over for the next panel, I just think it's important to know that Kansas hospitals are going to continue to do this work to really focus in on educating our delegation to ensure that CMS approves our provider assessment and our state-directed payments for our hospitals in Kansas. We're going to really also push for legislation to hopefully further delay or reverse any of the wind down to the Medicaid payments to that 110% of Medicare that will otherwise begin in 2028. With that, I'll turn it over to our others on the reactor panel.
Okay, thank you, Cindy. Robert, you lead the state's primary care association. Why don't you share a few thoughts with us, please?
Sure. Well, so yeah, we represent all of the federally qualified health centers as well as other state-funded safety net primary care clinics that serve everyone regardless of ability to pay. So really try to really serve as that backbone for primary care, especially for those who may have access or other issues getting care. And, really what we heard today is that there's really potentially substantial impacts for those that all of us serve that are on this call, and those that may need other resources as we look at some of the changes that may happen with the health insurance exchanges as well as with Medicaid. So right now, in talking about rural impact, 2/3 of our members are in rural areas and serve rural areas. And currently, we serve about 1/3 of the uninsured, or slightly more than that, 20% of Medicaid. And as we look at, like most of us, we're all doing the most we can with the resources we have. So as we look at these changes, I think it's important across all the components of the healthcare system, but also those that serve populations in need, that we really think about how do we invest or make use of whatever opportunities they are as we look at some of these changes. And, this changed healthcare environment is really going to be important for us as we think about it and how do we add that capacity across the healthcare system, whether it's hospitals or safety net clinics or other providers of healthcare, or even those of us that serve populations that may have difficulties with access. So, when we look at something like the Rural Health Transformation Fund, I think there's some real opportunities there in the midst of all the changes that we're likely to see. And, really commitments to things like keeping those that are still eligible or remain eligible for Medicaid and for the health insurance exchanges, keeping people insured and, really partnering on efforts to get that to happen. So I really think we need partnerships across both the healthcare spectrum, but also the social service spectrum and community spectrum, because this impacts our communities, it impacts the economic viability and health of our communities. And then really this focus on how do we use the resources we have to focus on prevention and chronic disease management, and even this idea of fostering health outcomes, which is one of the areas allowed for in sort of the general areas of the Rural Health Transformation Fund. And then I think we also have to talk about access across the healthcare environment, and then the workforce. The biggest issue we often face in our rural areas when it comes to providing care and being able to provide care is having a sufficient workforce and an appropriate workforce to meet those needs. So really pleased to see some of this initial work to understand what the potential impacts might be in Kansas, and also how we can begin to work together to make sure that all Kansans still have the healthcare they need and that all Kansans are healthy, even as we look at change in the healthcare system here.
Thank you so much to Cindy Mann, our primary speaker, and our reactors. I'm going to add just a couple of thoughts and themes that I've heard, and then ask David Jordan to do the same. And in the meantime, everyone, please feel free to put your questions in the chat, and we'll do our best to get through as many of those as we can. One of the things, the benefits I have of having been around this area for, in this particular role for more than 20 years and in working in the field more than 30, is that I've had the opportunity to see significant gains that were made and strides in reducing our state's uninsurance rate, in increasing access to high quality health care, and expanding the role of federally qualified health centers and other rural health provider models that have been good. We've seen the advent of certified community behavioral health centers during that time. All of these models are based on largely and successful because of the role that Medicaid funding plays in their support, as well as the marketplace opportunities for people to have coverage that they otherwise couldn't afford, and for those providers that are serving them to have a form of payment and revenue. So our foundation has really deep and grave concerns about these changes. In particular, we think we're going to see a significant uptick again in our uninsurance rate in our states, and particularly in very urban and very poor rural communities, similar to what we used to have before the passage of the Affordable Care Act. We're going to see an increase in medical debt, which is already a significant problem for Kansans. And we've had a situation where for just a moment, we thought that medical debt wasn't going to be held against people on their credit scores, but it looks like we're going back to that being a factor. And that means people can't get a lease, they can't buy a house. There are all kinds of things that come along with being burdened and saddled with medical debt. And a lot of these changes are coming on the backs of significant cuts to outreach and enrollment grants that the Reach Foundation has been leveraging through public-private partnership with government funding and our philanthropy to many organizations, including many on this call. And we're deeply concerned about the folks who are still eligible for some of these programs being able to get the assistance and support they need, because it's a challenging and difficult process. We were hopeful with some of the changes that we're going to allow more easy eligibility determinations and prevent kind of the churn off and on enrollment, but those have been put on pause as well now. So it's starting to feel a little bit like a lot of things all at once. And I guess my final thing would be to say advocacy works. We know it works because this bill could have been much, much, much worse if advocates, many on this call, hadn't reached out and done just diligent outreach to our congressional delegation. And we need to continue to do that as we move forward towards the end of the year. But we also need to turn our attention now to our state legislators who have to enact this, and to the administration who has to develop the application, for instance, for the Rural Transformation Fund. So I'm encouraged that so many people are here today and eager to continue to work with all of you. David, I'm going to have you do last minute. I'm going to take a question or two, if that's okay. The question from Brenda Bandy: does the Kansas Legislature LLC need to approve Kansas Medicaid's application for the Rural Health Transformation Fund? If so, could this be an issue? Somebody have an answer to that? Cindy Samuelson, possibly.
Yeah, my understanding is that should not be the case. They would not need to approve that, and I'm unaware our team has heard anything on the radar from the legislature on that.
Okay, and then April Holman has a question for Cindy Mann. Do you have a sense of the difference the new Medicaid expansion administrative burdens will make in terms of the potential number of new enrollees for future Medicaid expansion states like Kansas? Oh, you're on mute, Cindy. Sorry.
I think the question is focused on the work requirements that are imposed by HR 1 on the expansion population adults, which will create very significant administrative burdens both on individuals applying and trying to retain coverage, as well as on the Medicaid agencies and hospitals and health plans and navigators that work with folks. So, you know, we will see what the impact is. It's not obviously applying immediately to Kansas. I like the optimism in the question, which is that Kansas may turn to be an expansion state. I'm all for that. But I think we'll have to see. There's going to be an intense monitoring effort to go on to see exactly how people are affected by these new rules. We've certainly seen it in the waiver states that have done these work requirements in different ways that resulted in large coverage losses, and really sort of like unwinding procedurally based coverage losses, not because people aren't complying or aren't exempt, but because they don't get through the paperwork. So, you know, I'd love to think that it will go more smoothly than anyone has seen it happen in other states. But assuming it doesn't, I'd also love to think that there'd be a reconsideration of imposing those kinds of requirements on a health insurance program, which really distracts from its main goal, which is to make sure people have access to health care.
Great, thank you. David, I'm going to turn it back to you, but I do want to remind folks, we will be popping in a quick survey into the chat here shortly. We would love to get your feedback and input on, if this has been helpful, what else we can do, what you all are doing, and what you're interested in. So if you wouldn't mind taking a minute or two before we wrap up at 2. David, I'm going to turn it back to you while we wait for other questions in the chat.
Excellent. Thanks, Brenda. And Mark McCormick had messaged me just asking about the impact of Medicaid, and I think for Cindy and others in serving Kansans that live, because we talked a lot about rural, but to talk about Kansans that live in urban communities and some of the impacts that may be felt. I think I'll pull this out, but I think from an equity standpoint, we know a lot of disparities exist. Medicaid plays a key role in reducing disparities. Or it could be leveraged in a way. So if folks want to comment on that, but I would just say that Medicaid and the marketplace are critical to ensuring Kansans are healthy. Access to care is critical to Kansans. These changes will have a significant impact in making it more difficult for Kansans to enroll in coverage, to stay enrolled in coverage, and to be able to afford coverage. And as more Kansans become uninsured, as you captured very well, Brenda, there's really going to be a negative impact on our hospitals, our health centers, and our other providers and their ability to provide quality services. And then I think there's also just the fact that Medicaid plays such a big role, and healthcare plays such a big role in employing Kansans and in the state budget. So we really need to find ways to work together to try to address some of these changes with our policymakers, either at the state level or at the federal level, and to also just push back and build a health system that centers people that can be more responsive for the future. So I think we need to repair these cuts and then work towards a better future. But I appreciate everyone joining us on this call, and I think that's the start. This is the start of that discussion. And I know we have time for some additional questions. So
Yeah, and David, I
Thanks,
might
David.
just jump in on your question that you got through the chat, because I think it is important to note how interdependent hospitals in Kansas are. Our rural hospitals rely on our urban hospitals. Our urban hospitals rely on our rural hospitals as patients want to get care close to home. So we're so interdependent, and our urban areas truthfully have a lot of Medicaid, more so than many of our rural areas in the state. So although we talk about many hospitals in rural areas which are struggling financially, and this can be very detrimental, it does impact every single hospital in our state, rural and urban.
Yeah, and I would just underscore that as well. There's an emphasis in our conversation on rural just because of the fragility and the nature of rural communities. But this is going to affect every single hospital and many other providers. And just, state-directed payments have been a way for states to address workforce in all different settings, whether it's primary care, whether it's in home health. So it's not just hospitals, it's not just rural providers, it really is our healthcare system. And when you think about what Brenda said, which is, going back to the bad old days of much higher uninsured rates, that has impacts and will ripple throughout the system. So hopefully this is really, I've been doing this work for a long time. It's the first time in a very long time that there's been this kind of enactment that bring us backwards in terms of reducing the number of people with insurance.
Any other final thoughts, final words, final comments? Robert, anything else you want to add before we wrap up?
No, I think we all have to work together. And I really like this idea of the working across the rural healthcare spectrum, as well as including all of those that are kind of impacting these populations that are going to be really impacted by this, both our own communities, but also the individuals who may need access and the sort of financial and other implications it's going to have for our communities. I think that's really important that we work together to try to figure out how to minimize the impact and try to move forward with a real approach that'll continue to have increased health for Kansans.
Excellent. Well, there is, again, a survey in the chat. It's very quick. I would encourage all of you, if you are not currently engaged in any type of policy advocacy or organized thinking about how to communicate around these issues with elected officials. April Holman is on the call with the Alliance for Healthy Kansas. They put out great work, great website, a lot of organizing, a lot of storytelling, and storytelling is going to be very, very important. I had a reporter ask me yesterday, he said it'd really be nice to be able to talk to someone who is in this situation where they are going to be one of the people who's losing coverage. And I know that that's difficult. It's hard for people to do that, but for all of us on this call, we need to humanize this situation. And we talk a lot about the money, we talk about enrollment, but at the end of the day, this comes down to our friends and family and neighbors, and we need to be telling those stories and sharing those stories. So if you aren't engaged in this, if your nonprofit board is hesitant or reluctant about engaging in advocacy, this is our new reality, and we're all going to have to be pulling together and oaring together, rowing together in the same direction in order to protect as many people as we can in our state. And with that, I'm going to leave that survey up just like 1 or 2 more minutes, but otherwise, we appreciate your time.